from the liver meetings, what was relevant, and it was always an incredible meeting. And anyway, it was part of his many, many things that he added to all of our careers. So you already were introduced to Dr. Vierling yesterday, but we've asked Dr. Vierling today to be our TBR lecturer on update us on ascites, HRS, and portal hypertension. Very much.
Well, thank you, Paul. I can get my slides up. There we go. Well, it's a deep honor for me to present the Telfer B. Reynolds Award in his lecture today on ascites, the hepatorenal syndrome, and portal hypertension. And these are my disclosures. As you all know, Dr. Reynolds had a legendary academic career at USC. And for all of us in the room and internationally, he is a pioneer. He was a consummate clinical investigator, and I'll be touching on some of his contributions, which included the development initially of the wedged hepatic venous pressure gradient as a diagnosis for portal hypertension. He then studied surgical shunts for variceal bleeding, which of course then transitioned over to TIPS later, and ascites pathogenesis and treatment, HRS characterization, where he looked at the pathogenic roles of prostaglandins and plasma volume. He showed that autoimmune hepatitis was a DILI reaction to the over-the-counter laxative oxyphenicillin, and he conducted numerous randomized controlled trials, among which are those of steroids and patoxyphylline for acute alcohol-related hepatitis. He was a renowned educator, as you've heard and you know, an inspiring mentor to me and virtually probably everyone in this room. And those hundreds of fellows have now shared their legacy with hundreds, if not thousands, of trainees in his name. And I count it a blessing to have had him as a personal friend, and his wife, Kit. Now, for background to this talk, we'll start with the sobering age-standardized death rate of cirrhosis per 100,000 in the world. In this heat map, you can focus on the United States, where we have just slightly less than 20 per 100,000 deaths attributed to cirrhosis per year. You can see other countries have substantially more deaths. And overall, if you look at statistics, about 47% of those appear to be alcohol-related, the rest non-alcohol-related. Now, I showed this slide not because you don't know this, but because we have in our healthcare system and among patients and their families, the idea that the diagnosis of cirrhosis is a terminal illness, that the light switch has been turned off, there is nothing more to do. When in reality, we all know that cirrhosis is a process, not an endpoint. And the process is characterized by progressive worsening of clinically significant portal venous hypertension. To the left, you see the early phases of a cirrhosis. Obviously, you see the regenerative nodules circumscribed by thin bands of collagen. These patients are in need of new drugs, principally drugs that will reverse the underlying root cause of inflammation and fibrogenesis in their liver. To the right, you see the progression of the untreated patient has increasing hepatic venous pressure gradient as evidence of clinically significant portal hypertension until you get this kind of grizzled liver. And at that point, new drugs are probably not enough. This person needs a new liver. And so our challenge is to identify this and characterize it to our patients. When we look at cirrhosis in US adults in the top left, you can see that the prevalence is among the 290 million adults is about 1 in 400 overall, but see it's 1 in 200 between ages 45 to 54. And I think that this is not only a likely underestimate, it's a definite underestimate, because yesterday you heard about the burgeoning numbers of young people, principally women, with alcohol-related cirrhosis and liver disease presenting early in life. Now, the bottom left characterizes the kinetics of the features that define decompensation of cirrhosis: ascites, new onset jaundice, encephalopathy, and variceal hemorrhage. And you can see it's a stepwise increase. And in the first 20 months or so, it's only at about 5 to 10%. You go out to 120 months, at 10 years, you're up near 40, 50%. Now, the impact of this is great. If you take all patients with cirrhosis, they have a decreased life expectancy, but the median survival when they're compensated is about 9 years. But once decompensating event occurs, that drops to the yellow curve with a median survival of only 1.6 years. So this should trigger us to start thinking about prevention. And as we think about that, we have to keep in mind key anatomic and physiologic considerations. To the right, you see a cartoon of what I'm talking about on the left, and the portal vein delivers, as you know, high volume venous blood flow from the entire gut and the spleen, and it's under low venous pressure normally. Now, the volume of the portal venous flow is minimal during fasting, which is when you measure things like hepatic venous pressure gradients, but it's maximal after feeding due to reflex gut hyperemia. And in fact, in a cirrhotic, you might have a fasting hepatic venous pressure gradient of 10, and postprandially, it may be transiently 20 to 22, as Andy Burrows had shown in a large study in England. Now, portal venous pressure, as you know, is calculated as the resistance and portal venous flow product. And it's responsive, therefore, to either an increase in resistance or an increase in flow. And that sets the stage to say, well, how do we increase portal venous resistance in the cirrhosis patient? Well, we do it with fibrosis, which distorts that sinusoidal architecture. And so we have fibrotic tissue resistance. We have also occlusion of the sinusoids due to portal microthrombi, myoblast contraction, because these are myofibrils with actin, and when they contract, they constrict the sinusoid. And then we have increased hepatocyte volume, where the hepatocytes are swelling and encroaching on that sinusoidal volume, principally with fat. But we also have increased portal venous flow, and that is due to vasodilatation, and I've already mentioned this postprandial gut hyperemia that can drastically increase flow. And this is underlined by the pathophysiology of splanchnic vasodilation of mesenteric veins that occurs in cirrhosis. Now, the hepatic venous pressure gradient, which was put on the map by Telfer, Reynolds, and Sheila Sherlock during his sojourn training with her, is depicted here. You're aware that it is defined as the so-called wedged hepatic venous pressure, and then you subtract the free hepatic venous pressure. Well, it's not really appropriate to have it a wedged pressure. What you want is a balloon that is occluding the walls of the vessel so that the free tip, the pressure probe tip, is sampling the interior of that vessel. And unfortunately, radiologists worldwide don't want to blow up that balloon. They just want to wedge this, and they basically are creating pressure by jamming that tip up against the walls, which is some of the reasons that you get all these kind of extraordinary results that you can't interpret with a patient having a transjugular biopsy. To do this well is hard. And although this is the gold standard and has been recognized as such by the regulatory agencies, it's really not applicable in clinical practice, and it's very rarely applicable in large-scale clinical trials. But fasting hepatic venous pressure of 10 millimeters of mercury or greater is the strongest predictor of clinically significant portal hypertension, that state in which these complications of ascites, hepatic encephalopathy, variceal bleeding will occur. Now, if you look here, this depicts that probability of decompensating events, and you see that when it's greater than 10, you see the yellow line rising significantly, and you see that those that are less than 10, it rises, but there's a gap there of about 20 months. And even with those that are rising with clinically significant gradient of 10 or more, that first 20 months has a very, very low incidence of these complications. This is our window of opportunity as gastroenterologists and hepatologists to make an intervention that can make a difference in the patient's life. So here I've simplified that to say we're compensated when we have the gradient less than 10, and we become at risk of decompensation or have actual decompensating events when we're greater than equal to 10. And in that, we have disease progression. We're killing hepatocytes, We're inflaming the liver, we're replacing the mass with scar. So we've got the perfect storm of progression. This is when you want to treat the primary disease. This is when you can reverse this process in patients with hepatitis B, hepatitis C, autoimmune hepatitis, and NASH. You know this, it's in the literature. And that's the window of opportunity to aggressively identify the root etiology of disease and treat it. Now, what about everybody else that might already be decompensated? Well, we have non-selective beta blockers, and you're aware of their impact in prevention of variceal bleeding for those that have varices, and you're also aware of other ways in which you can do that, band ligation for large varices to obliteration. You have TIPS or surgical shunts. Now, liver decompensation and liver-related deaths are not going to be determined by us ordering hepatic venous pressure gradients. And hence the BAVENO groups have now met, and we now have their 7th conference set of guidelines, and non-invasive criteria of liver stiffness and platelets are now a surrogate for that hepatic venous pressure gradient. You see on the left that if you have either a transient elastography, and this could be done, in this case it was FibroScan, but it could also be done by Velocure technology as transient elastography. If you're less than 5 kilopascals, you don't have to worry about them having a compensated advanced chronic liver disease, which is what that CACLD stands for. As you move in the progression of cirrhosis, you start to see impact on platelets. When you're staying above 150, you're still in very good shape. But as you move from 15 kilopascal to 20 kilopascal, and your platelets are starting to drop, you can assume that this patient does have compensated advanced chronic liver disease without a biopsy and without further imaging. And as they advance further to 25 kilopascals, then you can assume clinically significant portal hypertension. And this assumption is validated for patients that have hepatitis C, hepatitis B, alcohol-related liver disease, and non-obese NASH. Now, that doesn't include everybody, right? But it is a hint that we can use platelets and we can use elastography to help us as a surrogate for the clinically significant portal hypertension that we want to address. You also have the FDA-approved HEPATIQ, which is a non-invasive test for perfused hepatic mass, liver volume, spleen volume, activity index, and fibrosis score, and an estimate of esophageal variceal size. It's basically a proprietary software analysis shown on the left with serial testing of an individual patient that you can see was relatively stable and then started to have decreased indices and indicating progression of their disease. And the bottom right you cannot read, so I've blown it up for you on this slide, is the kind of report which is going to say that this is a person who has severe disease and liver dysfunction, a normal volume, a moderate increase in spleen size, unremarkable hepatic activity index that they correlate with alcoholic inflammation, and that you can see estimated fibrosis score is cirrhotic, is shock stage 6, estimated esophageal varices are estimated to be large size. And you can see in the top right that the changes that had occurred in this patient. So this is an FDA-approved parameter. Future in this field will probably include the FDA approval of other liver function tests to help us understand the people at risk and those that we want to pay the strictest attention to in terms of priority of care. Now, prevention of cirrhosis and decompensation has led us to a renewed focus on the prophylactic use of beta blockers. Shown with the red stars for carvedilol and other non-selective beta blockers, which you know would be nadolol and propranolol in our general practice, we have the capacity of these drugs to change the increased intrahepatic resistance in its dynamic state. Remember, there's contractility, there's changes in that sinusoidal volume that can be manipulated. Beta blockers manipulate that. They also change the splanchnic vasodilation that is leading directly to portal hypertension complications and the retention of fluid. And at the top right, you see that they have a profound effect on the heart. This is good and bad, right? At a certain point of increased cardiac output, it's kind of chasing the tail of decreasing systemic vascular resistance, it's good. Past a certain point of cardiac reserve and failure, where you're starting to have diastolic dysfunction and you need the end diastolic volume and you need the beats per minute to generate cardiac output, it can be bad. Now, I call your attention to this recently published non-selective beta blockers to prevent decompensation of cirrhosis, the PREDESCI trial. This trial was aimed at assessing whether lowering the hepatic venous pressure gradient with beta blockers could decrease the risk of decompensation or death in compensated cirrhosis patients who had clinically significant portal hypertension. In other words, 10 millimeters of mercury or greater gradient hepatic pressure gradient. So I can only show you a couple of data points on this, and you can look at the actuarial curve of the placebo and the beta blockers, and this is the cumulative incidence of all the factors that they were looking at. But you can look at new onset ascites was reduced by 58% with the use of beta blockers prophylactically, and variceal progression in those that had baseline small varices, the size progression was reduced by 55%. So this is evidence that actually prophylactic beta blockers, independent of how we've been using them for eons to prevent variceal hemorrhage, might be of benefit to patients. However, they have the capacity that we've learned in the past to increase survival in patients, but it's only within that clinical window of opportunity I was alluding to. And that's the two columns on the left hand of this slide. And I want to call attention to what I boxed in red on the right hand of the slide. And that is, you have this clinical advancement of clinically significant portal hypertension worsening, this grizzling, this thickening of the fibrotic bands. This is coinciding with decreased cardiac reserve, as you see, and that also is coinciding with increased bacterial translocation from the gut, sending all sorts of signals to the innate and adaptive immune system to create a systemic state of inflammation. You can see it's increasing your sympathetic vascular tone, trying to drive the heart to be able to pump the blood into this floppy vasculature. And it's also maximally stimulating the renin-angiotensin-aldosterone system. And with it comes in the black line an increased mortality. Not something new to you, but it's the physiology that I want to emphasize. This is when beta blocker is detrimental. And we got to recognize when this is happening. How do we recognize that? Well, as we'll talk about it in a moment, we want to recognize it principally on the cardiovascular equation. But as we get there, we want to look at the issue of our topic of ascites, noting that cirrhosis is the dominant reason to have ascites in our clinical presentations, but there are other aspects or other processes that can create ascites, and they need your attention in the differential diagnosis. This requires that you actually perform a paracentesis. And although this has been in our guidelines also for decades, we have data from the VA and elsewhere that only about 30% of cirrhotics get a TAP. And a paracentesis with a patient admitted for new ascites is in the 20% range when you look at hospital records for the appropriate CPT codes. This is unacceptable. One of our messages has got to be that you need to interrogate the ascites. The pathogenesis of ascites that we've kind of all learned is on the right hand of this slide. That portal venous obstruction, portal hypertension, changes of local vasodilator, spanklet vasodilation, this decreased effective arterial blood volume that was the underfill hypothesis of Bob Schreier, activation of these various vasoconstrictor systems, signaling the kidney to hang on to sodium and water, and the preferential accumulation of ascites. To the left-hand side are things that are modifiable that we want to keep in our mind. That is that the hepatocytes are being attacked internally and externally, and within them they have inflammasomes. So they themselves are altering their gene expression, and they're creating necrosis and the release of damage-associated molecular patterns, while that leaky gut is translocating pathogen-associated molecular patterns into the portal venous system, activating the immune system and leading to this systemic inflammation. And that is contributing to portal microthrombi, which is part of the resistance in portal hypertension. Now, you know that the diagnosis of the etiology of ascites is aided greatly by our use of the person undergoing paracentesis when we check the serum to ascites albumin gradient in the ascites total protein. That's another contribution of Dr. Reynolds, because to the left you see the classic paper on this with John Hafes, a fellow, and this work was done after his graduation from fellowship in Canada. And you can see the last sentence, that our results suggest that elevated gradient is usually associated with increased portal pressure, while a low gradient occurs with conditions where portal hypertension is usually not incriminated in the genesis of ascites. To the right, you see the classic study with each dot representing a patient of Bruce Runyon, another fellow of Telfer Reynolds, done at USC. And you can see portal hypertension in cirrhotic ascites and cardiac ascites. And you can see that that's differentiated by the total protein, as shown in the bottle panel. Nothing that I think any of you don't know, but if we don't perform paracentesis, we don't get a chance to look at these things and to diagnose the outliers such as malignancy or other reasons for ascites. Now, this is a busy slide, and I really want to focus on only a couple of things. This comes from Florence Wong's recent review, which I commend to you, and it's about sodium balance. If we restrict a patient to 2 grams sodium, we're restricting them to 88 millimoles of sodium per day. And that corresponds to a normal capacity of a normal person or a person with compensated cirrhosis to eliminate 78 millimoles in the urine, and there's 10 millimole loss from other sources. So now they're going to be in this balance, 2 grams in, 2 grams out. Now, if they happen to have ascites, they will stabilize the ascites. If the ascites is sort of clinically significant and with protuberance, in order to get off of that stable basis, you need to add some diuretics to kind of whittle down the ascites while keeping the sodium balance. If a person is exceeding that limitation, you can detect that with a simple spot urine, sodium being greater than potassium, and it has a 90% accuracy to indicate that they're not adherent to 78 millimoles. Now, it's not always that they're out with a cheeseburger and a bag of chips. Sometimes you find that they're baking fanatics, and it's baking soda that's contributing all the sodium in their diet. You sometimes really have to dig to find how they can help themselves be more compliant. When they are exceeding this, and let's just use the example of 2 grams of sodium in ascites, they go from 2 to 4 grams. That extra 2 grams on a daily basis over 7 days will generate 4.6 liters of ascites. So if your patient is getting a tap every week of 4.6 liters, you can be pretty well sure they have 4 or more grams of sodium per day. And the importance is that that doesn't make it refractory ascites. Refractory ascites has to be defined as the basis of what is happening with ascites, its formation, and its ability to be regulated when you have ascertained the right sodium balance is being in effect, and diuretics are inappropriate or causing an increase in creatinine. And this is a physiologic state. That's the point of this slide. Now, when a person has true refractory ascites, then we have modalities that can be considered, such as large volume paracentesis, TIPS, or in the future, there may be alpha pumps or other things. This, again, comes from Florence Wong's illustration in her review article. But then we have to be considering where the patient is on this continuum that I've shown you of the progression of clinically significant portal hypertension. And key in our considerations of how we're going to be addressing patients with portal hypertension and ascites is the role of albumin. It has pluripotent treatment roles for the complications of cirrhosis. It involves endothelial stabilization, it's an oncotic pressure, it has immunomodulatory effects, capillary permeability effects, and you can see as you work on down that it has the capacity to influence a number of physiologic states. So albumin is not just a volume expander. And we know that because when it's compared to volume expanders that do the same amount of volume expansion, it's superior in many ways. So what are its indications? Well, the prevention of paracentesis-induced circulatory dysfunction, prevention of the induction of HRS-AKI by spontaneous bacterial peritonitis, prevention of hyponatremia, in combination with a vasopressor for the treatment of HRS-AKI. This looks at the ability of albumin to prevent paracentesis-induced circulatory dysfunction in cirrhotic patients. To the left of the vertical line in this forest plot is favoring albumin, and when it is clearly not touching that vertical line, it is statistically significant. This is a meta-analysis of all these studies you see listed in the different rows, and albumin clearly prevents post-paracentesis circulatory dysfunction. It also prevents HRS-AKI and mortality in cirrhotic patients with SBP. To the left, you see the paradigm you all are aware of diagnosing the presence of SBP based on a nutracetic ascites with greater than 250 neutrophils in the sample. And then you move to expanding the patient with albumin on day 1 and day 3 and treating with appropriate antibiotics. And to the right, you see its ability to prevent the progression of SBP to HRS-AKI. And in the bottom, you see its prevention of mortality of those patients. So this is something I think you're aware of, but it's another obvious use and well-established use of albumin. However, if you ask the question another way, I have a patient comes in and they're cirrhotic and they're in the hospital. What if I give them albumin? Can I just prevent AKI? It's not so clear. There's an overlap there. So in a statistically significant evidence-based manner, it doesn't prevent AKI in cirrhotic patients, but it does prevent hyponatremia in cirrhotic patients, and this may be of a consideration for your clinical care of the individual patient. And it also may prevent mortality of your patient independent of them having SBP. So albumin has a lot going for it and should not be, I think, regarded with caution in terms of the regulation of its use. But the one that stands out, don't give it because you want to prevent AKI. Do give it if you want an appropriate infected patient, SBP patient, to prevent HRS-AKI. Well, how do you prevent spontaneous bacterial peritonitis? These are data that come from older studies, the meta-analysis done by the Cochrane group, and you can see that prevention of SBP on the top and prevention of mortality on the bottom are both clearly helped by prophylactic antibiotic use. This happened to be all dominated by norfloxacin studies, and norfloxacin is not readily available. Its advantage was it wasn't absorbed. And because it wasn't absorbed, it was doing all of its prophylaxis within the gut. When you then look forward, and we changed to Bactrim, we went to ciprofloxacin, and you're all aware of this. Now the current data, I don't have time to share you, including data at AASLD, show that about 40% of our infections are resistant to prophylaxis with Bactrim or Cipro or other antibiotics. So in order for you to know whether you should use prophylaxis, you need to know the nosocomial and the environmental infection risk and resistance profile to decide. It may be actually better for you not to prophylax and deal with an infection that's treatable than to prophylax and deal with an untreatable resistance that you've helped create. So it's muddied the waters. Now, there's also interesting information of potential bearing on our practice, and that is the risk of SBP is increased by proton pump inhibitors. And we really can't go through all the data, but we should keep this in mind as whether this is something that our patients should not be on chronically. Now, this looks at prevention of SBP specifically with rifaximin use versus antibiotics, or rifaximin versus no antibiotics, the top and the bottom panel. And again, one sees a strong indication of rifaximin playing a potential role in the prophylaxis. And this muddies the waters further because, as you know, its major role is in the small intestine. It doesn't have a major role or concentration within the colon where we think the action is. So this tells us that if this works, we need to pursue an understanding of how. But if you happen to have a patient that deserves rifaximin for long-term management of hepatic encephalopathy, they may be getting that benefit. So we come back to remind you that to the right, we have this progressed patient, decreasing cardiac reserve, increasing mortality. And what is this all about? Well, it really is a reflection of cirrhotic cardiomyopathy. And that is involving a number of inflammatory mediators, the ones we don't consider a lot, many of which are driven by that bacterial translocation from the gut, bile acids accumulation, and these vasodilators. And it leads to an adaptation of the heart that ultimately gives out under the stress of increasing volume overload or the stress of a loss of volume, because these are diastolically dysfunctional hearts. You got to be right in the sweet spot of the Starling curve, just enough end diastolic volume to get a good stroke output. You can't be too much, you go into failure. You can't be too little, or you go into an output failure. And the mechanisms, we don't have time to go on in the right, but this systolic diastolic dysfunction precedes, but does not necessarily precede by far the systolic dysfunction that will occur. And the newest things that are coming out is the actual identification of receptors that are mediating this for bile acids. And this work of Desai at our Texas Children's Hospital at Baylor College of Medicine involves human studies and model studies in which he can antagonize the bile acids to then not signal through those receptors, and he can actually, in his models, resolve the cardiac dysfunction of cirrhosis in these models. So stay tuned for ways like this and others that we can address this problem. Well, the context I've just described for you is relevant to our next topic, and that's HRS. And the classic description that we all learned was this intense reversible cortical vasodilation. Here you see it in the hepatorenal syndrome, in the same kidney post-mortem when there was no vasoconstriction, showed normal architecture in its arteries. This is Murray Epstein's famous picture from decades ago. When we look at HRS, we first have to consider renal dysfunction is common in cirrhosis, and we have to understand that it has multiple etiologies. We do not want to ascertain that everybody who has cirrhosis that has renal dysfunction has HRS. This is a common problem in terms of the listed differential diagnosis by house staff and fellows. But it is a rarity. And when you look overall in published series, and there's always a bias of published series, right? Referral bias, a medical center that publishes their results, et cetera, it's about 12%. Now, the classification is important. You go through this. It's about the differential of pre-renal, and particularly important with the hypovolemia, and secondarily important, it is characteristic of the HRS-AKI, intrinsic renal disease, obviously, and then obstructive uropathy. And so this is the thinking that we must go through with each and every patient. We must also always keep in mind that serum creatinine overestimates GFR in cirrhosis. You see this curve, and you see the normal subjects, and you see the shifted to the left are cirrhosis patients with ascites. And by shifting that to the left, it means that your serum creatinine at about 1.5 grams per deciliter corresponds to a GFR of about 30 mLs per minute. And you're going to have an estimate on your eGFR on the lab that's going to tell you it's around 60, and it's not, because it's shifted to the left. And this is due in part to progressive sarcopenia in cirrhosis. We're not generating creatinine. We've already heard that it really is disadvantaged for females because lower body size, lower intrinsic muscle mass, and then sarcopenia on top of that makes this an insolvable equation. And that's partly why they're disadvantaged by MELD score using serum creatinine. Prevention is to avoid NSAIDs and ACE inhibitors. That avoiding of NSAIDs was really the contribution of Telfer Reynolds once again. He's the one that said that if you're going to prevent the prostaglandin activity, you're going to have the risk of renal failure. You want to withdraw diuretics. You often see reduce the dose or withdraw. No, you want to withdraw. You can always reinstitute, but you want to withdraw because you need to see what the consequence of withdrawal is. Limit lactulose to prevent dehydrating diarrhea. Maintain a mean arterial pressure with volume and vasopressors, and discontinue non-selective beta blockers if they have cirrhotic cardiomyopathy. Well, I already kind of alluded to this, that our old HRS type 1 is now redefined and categorized as HRS-AKI. And we're going to focus on this top line because this is the presentation that we're going to see in our cirrhotic patients. It has a multifactorial pathogenesis. Again, the stars contributing show the contributions of cardiomyopathy in decreasing the effective arterial blood volume, decreasing vascular resistance, and then we have the inflammatory response. These are all involved in the pathogenesis. The diagnostic and management algorithm from the AASLD shows that you first want to think of AKI at early stages and go through, as shown on the top left, a risk factor management. Get rid of the nephrotoxic drugs, withdraw the diuretics, detect and treat infections, etc. Now, as you move forward, if that does not resolve it, you now add the albumin up to 1 gram per day with a maximum of 100 grams, almost regardless of body weight. If this over 2 days is not producing a resolution, then you have to ask, are they eligible for vasoconstrictor therapy in addition to albumin? And you're categorizing them now increasingly as HRS-AKI. And there you have to go through a risk assessment as shown in the box. You have to know about cardiac diastolic and systolic dysfunction. You can best do that at the bedside. You're looking for jugular venous pressure, Rawls, and physical examination and 2D echocardiography. Do they have pulmonary disease? Do they have volume overload? You've either given too much albumin, too much crystalloid, or they're just volume overloaded. They have grade 3 acute on chronic liver failure, and do they have hypoxemia? And all those go into considerations of whether a vasoconstrictor could be used. Now, vasoconstrictor comparisons are shown in this slide. They all have IV albumin plus a vasoconstrictor. As you see on the table to the right, that terlipressin and albumin outperforms placebo and albumin with an odds ratio of 3.3. If you look at terlipressin or norepinephrine with albumin versus midodrine, albumin, and octreotide, they outperform with an odds ratio of 6.79. If you ask about terlipressin and albumin versus norepinephrine and albumin, they're not statistically different. However, there is a subgroup of patients where it's very difficult to use norepinephrine in the ICU. If you have to give high doses of norepinephrine, you go on the other side of the curve and you will create a state of cardiac dysfunction and reduce cardiac output. That is one of the detriments that those that have used it in the absence of another alternative have found. So what about terlipressin? Well, you know a lot about it. I'm not going to go through all this except to talk about it has the ability to increase effective blood volume, reduce renin and angiotensin through renal vasodilation, improve serum creatinine, and it acts with splanchnic vasoconstriction, so it's going to bring that pooled volume back into the systemic circulation. It does have a risk of hyponatremia, which you're going to countermand as a secondary effect of the albumin you're going to use with it. So this is the classic study, the confirmed trial that was published in the New England Journal of Medicine, a randomized controlled trial of terlipressin versus placebo after an albumin challenge of 2 or more days, just as following that algorithm from AASLD, looking for resolution with volume expansion alone. It looked at the incidence of verified HRS reversal, defined as 2 consecutive creatinine values less than or equal to 1.5 milligrams per deciliter, at least 2 hours report by day 14. The subject had to be alive without renal replacement therapy for at least 10 days after achieving verified HRS reversal. The serum creatinine values were excluded after RRT, TIPS, liver transplant, open label vasopressor use, and it must have been obtained within 24 hours of the final dose of the study drug in order to meet study criteria for analysis. That represents the intention to treat population. You can barely read this, but they're well matched demographically, especially in terms of the overall mean arterial pressure, although there's a little bit of an increase in those that, they're well matched in terms of sex and demographics. This is a US study, predominantly Caucasian. The Canadian portion of the study was about 10% of the patients. When you looked at the mean arterial pressure, you can see at the top it was comparable in both randomized groups. Those starting with less than 65 millimeters of mercury was a much higher percentage of patients in the terlipressin randomized arm, and you could see that the variations were relatively insignificant with acute on chronic liver failure grade in the baseline Cliff SOFA score. So to the bottom line, there was a higher incidence of verified hepatorenal syndrome reversal using terlipressin. There was a higher incidence of verified reversal in patients who had had prior midodrine and octreotide use. That is a key slide, I think, for us because we've been using that as our fail-safe. There were 4 pre-specified secondary endpoints: the incidence of subjects with HRR reversal, durability, incidence in patients with systemic inflammatory response, and incidence of verified HRS without HRS recurrence by day 30. So let's look at the data there. The durability favored the use of terlipressin and albumin. There was a survival advantage for verified HRS reversal as defined by my prior remarks. HRS reversal in patients with systemic inflammatory response syndrome was statistically significantly higher. You can see it's almost 5-fold higher than it was in the placebo group. So that particular subgroup of patients really benefited from its use. And verified reversible without recurrence by day 30 was not statistically significantly different in the groups. And this gets to the point of emphasizing you don't get HRS-AKI unless you have severe dysfunction with your circulatory system driven by that cirrhotic cardiomyopathy and severe clinically significant portal hypertension, giving you that sort of refractory state where you are in dire straits. That doesn't change because you treat, in this case, the HRS as a complication of it. It's the underlying disease and its intensity and severity that makes this not statistically significantly different. The change in serum creatinine is shown here, and this looks at the differences with terlipressin in dark blue and placebo in the light blue, as again statistically significant differences. And those that had a decrease in their baseline serum creatinine by greater than 30% were also statistically significantly larger proportion in terlipressin treated patients. The change in creatinine clearance now from baseline to end was also statistically significantly different. And this is without interaction and with interaction analyses that I don't have time to go into. And then, very importantly, the length of stay in the hospital was no different between the two groups in the top row. But the time spent in the ICU was decreased by almost 50% in those that were treated with terlipressin, which gets in part to the question I was asked by Paul Pakros yesterday: how do you justify the potential use of terlipressin, and what is its overall meaning? There is some cost advantage, but there's also an advantage that you saw yesterday presented that looked at the transplant population that had gone from this study, in that they need lesser RRT, they have better retention and restoration of kidney function following transplant than these others. And of course, if you go on past this and worsen, then you're in that real nightmare of requiring 6 weeks of RRT to qualify for a kidney transplant simultaneously with the liver. You heard yesterday, and we emphasize again, there's a boxed warning. The boxed warning is about serious or fatal respiratory failure. And this is why you need to know the cardiovascular and respiratory status of your patient. This was very problematic for the FDA. And we had to kind of talk to them and remind them, as did our colleagues in cardiology from around the world, that we knew all about this, because before we had octreotide, what did you do for variceal hemorrhage? You used vasopressin. And when you used vasopressin, you knew that this was the consequence if you had volume overload, underlying cardiorespiratory disease. We kind of learned that this was a manageable and mitigatable. And ultimately, if the risk is too high, you don't use it. And that led to this list that you can barely read, but you can follow up in the package insert, which is where this is from, that you really have to select your patients carefully. There's some patients who may meet certain criteria, but from a cardiorespiratory standpoint, they are at risk. Now, there's also buried in the second line under warnings and precaution, this statement about potential ineligibility of liver transplant. That has to be an individual decision based on the patient, their characteristic and eligibility for transplant. And it has a lot to do with what MELD scores can be transplanted in your particular region. Your region requires very high MELD scores. So it's stating that if you change the serum creatinine, that you may disadvantage the patient by reducing their MELD score and taking them out of candidacy for organ offers. And that needs to be an individual decision that the hepatologist and the transplant surgical team needs to address. Now, this looks at higher incidence of verified HRS reversal in patients treated with terlipressin versus norepinephrine. I showed you before that in that study, a meta-analysis study, there was no significant difference. Here, you start to see some differences, and this is coming from the Aurora study in hepatology in 2018. So it has to do with the patient population. If you require a lot of norepinephrine in order to have an effect, and it's now in a toxic range from a cardiovascular standpoint, it won't work. Terlipressin has a superiority there in terms of protecting the heart. If we look at predictors of irreversibility of HRS-AKI, you have, from this publication, age, total bilirubin, an indicator of hepatic function, nosocomial infections, and reduction of creatinine less than 0.3 on day 3. And you can see what is happening in terms of the probability of survival in patients not eligible for transplant if you have evidence of irreversibility. So this is something that you want to diagnose quickly, you want to attempt to treat, and you want to have a plan B and a plan C if they don't respond. And both plan B and C is transplant if they're eligible for it. Progression to irreversibility is that it progresses to a tubulopathy and ATN. And with that, you'll develop bile cast nephropathy and the proximal tubulopathy of granular casts. So you can measure whether that's happening with a simple urinalysis microscopically. That's helpful at the bedside to know. And when you think of all the nephrons in a kidney, there's going to be a few of them that are probably transitioning to ATN as you're treating. The whole thing is if you can keep that wave from involving a significant mass of the kidney. So let me illustrate my take-home points by first on the fact that it's an honor to present this lecture and for named in Telfer B. Reynolds' name, and reflect on his goals and our goals collectively to prevent progression to cirrhosis, That's where our major impact can be of hepatologists, early diagnosis and prevention, vaccine prevention of preventable viral disease, decompensation of compensated cirrhotics, development of life-threatening complications of clinically significant portal hypertension, where early use of non-selective beta blockers may have a role, and of course, to early identify and therefore successfully treat HCC. Now, clinically significant portal hypertension and the risk of portal venous hypertensive complications are defined by the hepatic venous pressure gradient. The surrogate is the BAVENO 7 criteria. Perfused hepatic mass and liver function can also be useful clinically. The PREDESCI trial gives us hope that non-selective beta blocker prophylaxis could delay decompensation in those with already clinically significant portal hypertension. The serum to ascites albumin gradient is a key for diagnosis. Albumin after large volume paracentesis prevents the circulatory dysfunction, hyponatremia, and reduces mortality. It's key in preventing an SBP, HRS-AKI, and mortality. And in refractory ascites, it is important because it's a manifestation of hepatic and cardiovascular function, and that's what you need to recognize as the risk that sets the stage for HRS-AKI, which is infrequent. However, albumin and vasopressin is the worldwide standard of care, and I would submit to you that terlipressin worldwide now is the preferred vasopressor in the absence of contraindications. Thank you very much for your attention.